Okay, for the big assessment. So these are the components. Your first goal when you do the 30-minute mock thing on Monday, do not forget a section. There's only 4. It's happened. It happens on OPDs. People get nervous and they totally forget observations. But do not forget a section, because there's a reason why you do these sections in this order. And it's mainly for patient safety. If you jump ahead, you might hurt the person. Okay? So please do not forget a section. That is your first goal. That's the only thing we're expecting on Monday when you do an assessment. Okay? We're not expecting like your history to be like, I'm not going to miss a single question. That's not the expectation. Make sure you talk to the person before you touch them is the goal. Talk to them. Get as much information as possible. That's your subjective examination before you move into your objective examination. How many times you've gone to the physician, a bad physician's office, and you walk in the door and they just start taking your temperature and everything else without even saying anything to you? Sometimes it happens. You need some direction, and that direction comes from the history. At the end of your history, in this class, you will start off at a 12-minute time limit on the CHA exam. Because you have only 30 minutes, a good guideline to strive for is 6 to 8 minutes history taking. You will develop your own process and flow that is comprehensive. You will. I guarantee it. With practice. And everyone's flow is going to be different, and that's fine. It just has to be complete. We will give you a list of things that you must include in your history. How you organize it and how the conversation evolves is completely up to you. And in my experience, the way my process is for one person is always different than my process for a different person. My flow. Because it's a natural conversation. Okay? It makes the person a little bit more comfortable when it sounds like you're having a conversation. Okay? In the middle of, so how did you hurt it? Do you have allergies? Like, where did that question come from? Okay, after I get all my pain questions, I normally take a side tour, or whatever, and say, I'm just going to ask you a few other questions just in case, but I just need to fill out the rest of this form. So do you have allergies? Well, sometimes that part comes a little bit sooner, sometimes it comes later based on the conversation we're having at that moment. Okay? What you need to be able to do on Monday is don't forget the history. Okay? If you're comfortable with that, your next step is to make sure that it's as comprehensive as possible. Okay, so we'll give you a list of things to ask. Just make sure you include all those things in your conversation somehow. Now, at some point, you're going to organize those questions in a good flow for yourself. That's the purpose of those assessment forms that you're going to make for Janelle. At the end of the history, indices of suspicion, make sure you have 3. It can be in any order you want, but make sure at the end of it you're like, well, I think it's this, and I think it's this, and I think it's this based on what you told me. But we'll continue on with the assessment so that we can figure out which one of these 3 it potentially is. State it. Just like a normal conversation. If you go to the mechanic and they've looked at your car, what's your question the first time they come out of the garage and meet you? What's wrong with my car? Well, I think it's this. I think it might be this too. But we'll do some other testing to see what it is. Okay. As soon as the history is done, we move into the objective examination. In some books, it's called the physical examination. But in this class, we'll call it observations. In Arnheim's book, he calls it inspection. Same idea. At the end of the observation, so the observation is made up of 2 sections. There's a static observation, anatomical position, or just normal. Okay, anterior, posterior, right side, left side. And then dynamic. Get them to walk if it's lower body. If they're a runner, get them to jog. If they're complaining of pain when they're jogging. If it's upper body, we do abduction and forward flexion to look at scapular movement. Okay, so there's your static observation, there's dynamic. That's not written in the book. It's scattered. But I feel that that's a better way to organize it. Okay? Because all you're doing during a dynamic assessment is you're just watching them. So that's your observation. At the end of the observation, your indices might change. Realize that, be comfortable with that. That's fine. Based on your observation, based on what I've seen, I think I'm going to change my guesses. Instead of it being this, I think it's actually this now. And that's okay. Because now, as an examiner, I know what you're thinking. And I like to see that you're considering what's in front of you, what you saw, as part of your assessment and how that contributes to the injury. Under examination, we have scanning or clearing. So let's just say, for example, we'll get more into detail with this. There's a lot of situations where a person will complain of something. Let's say they complain of something in their knee. Pain, numbing, tingling, whatever. Realize that although the pain presents in the knee, the problem could be elsewhere. I hope that makes a little bit of sense. Right? So let's say you have a flood in your basement. All the pipes that you see against the wall are right there. Could the water be leaking from those pipes, or could it be leaking from elsewhere? It could be leaking from elsewhere. It might be leaking from a pipe upstairs, or from a pipe from below, or maybe a crack in the wall. But you need to realize that the pain could be presenting there, but it may be stemming from someplace else. Give me a physiological example. A condition that you know of where the problem is in one spot, but it presents with pain or symptoms elsewhere. Heart attack. Where's the problem? Where does it present? Let's say you have a spleen injury. Where's your spleen? Left side. Where does the pain present generally? Left shoulder as well. So now we've got left shoulder symptoms. What's the difference between a heart attack and a spleen injury? Simple answer, I think.
Life and
What's that?
life and death.
Life and death, but with respect to the cause. Think of a mechanism. Difference between a heart attack and a spleen injury. Perfect. One's traumatic, one's not. Well, I mistake. You could have a traumatic cardiac arrest. Emotional cordis, you get right in the middle of the chest. 2 lacrosse players have died in the last year in the States because a lacrosse ball hit them in the chest. You get it right at the moment, heart stops. Whether they had symptoms or not, it all happens too fast. Okay, but in the problem we just talked about, one technically is traumatic and one's not. So again, you're putting 2 and 2 together. For the knee injury, where could the pain come from? What's one spot? Sorry? Could come from the hip. Could come, simply speaking, could come from above. It could come from below. So scanning and clearing is meant to assess those areas first. Okay. Generally speaking, if you think from your history, all 3 of your indices suggest it's a chronic injury, then because with chronic injuries, it can stem from almost anywhere because it's ongoing, you need to check more areas. And you also have to do neurological testing. Okay, now if I fell and bumped my knee on the floor and I come in and I'm complaining about my knee, there's a specific mechanism. That's an acute injury. All that information I got from my history, I don't really have to go to the low back. Okay. In fact, I'll argue you don't even have to go to the hip or to the ankle, because you know what the specific mechanism is. Now, if it radiates up into the leg or down from that mechanism of injury, then I would probably check out the hip and the ankle just to be sure. Okay. But that's essentially what a scanning and clearing exam is. Don't just focus on the area, but focus around the area as well. And again, we'll show you how to do that. Once you've cleared other areas, again, state what you think it might be. Again, it might change, So you might have had 3 up there. You might have been a new 3, and you might have changed the order of the 3. And that's okay, but you need to tell us what you're thinking. And then you look at the specific jointing question. Range of motion testing. Range of motion is active and passive, RIM, or resist isometric. In some places you see RRM. I've always used for active, passive, and resisted range of motion. Active, passive, and resistant. And I've seen people use end range of motion this way too. End range of motion is your checking your end fields. Okay, the end fields where you take them all the way to the very end, and it should feel a particular way, and if it doesn't, then you have to say that the end range of motion is either abnormal or it's normal, or there is no end range of motion because the thing's not even in place; it's a dislocation. So, but those are again different acronyms. After you clear the joint above and below, you look at the joint in question and you do range of motion testing. Always start off with active, because that'll give you some information before you do passive and resisted. Well, again, we'll get to range of motion testing in a second. As soon as you do all those movements, that normally takes up a chunk of time, by the way. So these two, 12 to 15 minutes generally. Observations should probably take about 4 to 5 minutes at the most. Okay, so, but this takes up a lot of time. Special test and palpation goes by rather quickly. Okay. As soon as you're done with range of motion testing, as part of your physical exam, we do special tests. And special tests are meant to confirm or disconfirm, is that a word? Confirm and rule out. I have to go a different word, but confirm or rule out your indices of suspicion. So at this point, now this is important. This indices is important, because that's the indices you're going to use to align your special tests. So whatever 3 conditions you think the problem is, you have to use a special test to confirm or rule them out. Okay? So let's say stretched deltoid stretch, anterior talofibular ligament, and stretched calcaneofibular ligament. So 2 of them are medial, 2 of them is lateral, 1 of them is medial on the ankle. Okay? So you'd have to figure out a test for each one of those, at least one. Apply those tests. 2 of them will rule out 2 of those conditions. 1 of those special tests will confirm 1 of those conditions. Can you do 2 special tests per condition? Absolutely. But don't do everything in the book, because now you're going to make the person uncomfortable. It'll be painful. Is there a special test for a bruise? Because that could be one of your indices, just a contusion. Right? What's the mechanism for contusion? Let's work backwards. Yeah, someone just hits you, right? That's the mechanism of contusion. If you get hit hard enough, it breaks, or you crush the muscle, right? So, in that particular mechanism, fracture or contusion, how do you rule it out? Tap test, you do your fracture test. Tap test, compression, POTS, fulcrum, there's all sorts of fracture tests you can do. Let's say it's not painful when you try to stress the bone, you're fine. Could it be a muscular strain? It could be. You can do some muscle testing. But let's say you rule all that out. How else can you rule things out? It's kind of a trick question, I think. That's right. Okay, manual. So you can use any other part of your assessment to rule something out if you want. But you have to verbalize it. Part of my indices was contusion. I had ruled out all my other 2 indices. And just for the fact that in my observations I saw discoloration and swelling, and the fact that it was a traumatic injury, I think it's a contusion. There is no special test for that. But to set up your rehab plan, because that's what we're trying to do, figure out where all the problems are so we can fix them, to set up a great rehab plan, you have to do your range of motion testing to determine what kind of range of motion exercises you need to fix this person. What type of strengthening exercises you need to fix this person as well. Okay? So everything that you do in here, more specifically from here up, everything you do in your assessment should help you develop a rehab plan. Okay. And last but not least, palpation is the very last thing that you do. Now there's debate, do you do palpation before this or whatever? Intuitively, people just like to poke and feel around right away. McGee says to do palpation last, especially for chronic conditions, because if you start poking around too early, you're going to irritate everything. If you irritate everything, this might not come back accurately. And some of these other things might not come back accurately as well. Okay, so don't poke around right away. Now with an acute injury, they flip this. They actually do palpations back here to kind of isolate whether or not it's a bone. Because if there's pain on bone, your first special test is a fracture test. Okay? But we'll talk about that in field class more. And once you're done, I don't know if you guys can see that in the back. At the bottom it says clinical impression differential diagnosis. What do you think it is? I think it's this because this is what I found. I don't think it's these other two because blah, 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 blah. You have to be able to rationalize that, and if you cannot, you need to do a better job in your assessment. If it's not clear in your mind what the injury is, then you haven't done a good enough job. Okay? So you need to feel comfortable saying it. And if you're not sure, that's okay. Just be like, you know what, I'm not sure exactly what it is, but let's try a couple more things. Okay? That's okay. You might change your mind. You might change your mind 5 times. Nothing wrong with that. Things pop up. Okay? So any questions about the process? So on Monday, what your goal is, do this in that order without forgetting a step. Now, if you forget something in range of motion, like, damn, I forgot to do plantar flexion, that's okay. There's way too much to remember. What I want you to remember is don't forget a step and do it in that order. Okay, so make that be the goal on Monday.
So when you're like on the field when a player like went down, what would you do? Like what steps would you like kind of open for the sake of time and then do the bomb?
Fantastic question, because that's what you guys are doing now. Okay, so I was hoping to wait till Thursday to talk about that, but if stuff happens, you guys have to be prepared for it. So there are some things you can leave out. I wanted to ask about FAMSO history. We'll talk quickly about, like, do you guys want to know? Is that going to help? Would you guys rather do that? It'll take about 5 minutes. Okay. There's a lot of things you can cut out of this. So this is meant for a 30-minute clinical assessment, this template. Okay, the field template, and that's why I said Schultz is a good book, because you can see them side by side. I have a PowerPoint that has them side by side, and I'll tell you how to flip things around and what things are more pertinent for the field scenario. Okay, so you're on the football field, somebody went down. Let's say that, okay? So history. Think about what questions are really, really important on the field that you need to ask right away. Let's assume you know the person, so you don't have to do the instructions, because at STS you might. Right? If it's a little Jimmy, but you don't know their name, they don't know yours, the first thing you might want to say, hey, how's it going? My name is Dennis, everything will be fine. Oh, here's your coach, Tom. Tom, can you say hi? My parents, okay, everything will be fine. And just do that for a good 30 seconds. The rest will be fine. And then get into your assessment. So what's one question you need to ask right away? What happened? Simple question. What happened? Tell me what happened. And let them explain. What's the one thing you want to try to rule out right away on the field? The one condition before moving them. Fractures you want to rule out before moving them. Because if they're fractured and you don't want to move them, you might even have to call EMS. So the next question is sounds or sensations. Did you hear a crack? they heard a crack, you need to slow down with your assessment. Take your time now. If you didn't hear a crack, then you could potentially move. But you need to rule it out. What's the next step after observations? Sorry, that was a bad question. What's the next step after history? Observations. Okay, so again, you're thinking fracture. If they're not fractured, we can move them. What's the one thing you might be able to pick out if it's fractured? If it's obviously deformed. Okay, so you're looking for that. If it's not, if you can't see the area, you might need to expose it on the field. Especially if they said, I think I might have heard a crack. Slow down and expose, even though it's a shoe. Take it off. Okay? Because if it is angulated, you don't want to do a two-person walk assist and something happens and then now it's an open fracture. Now there's infection. Now you're good. Okay? So just a couple history questions. Fine. What happened? Pop, crack, crunch. Have you heard it before? Give you a number 0 to 10. Okay? Based on what they tell you from those basic 4 or 5 questions, you either ask more questions or just move on. And we're assuming we're talking about traumatic injuries, not medical. Because if it's medical, you need to ask more questions before you move on. Okay? So history, let's say maybe a fracture. So you go into observations, you expose, you don't see anything out of the ordinary. And if you do, you're obviously not going to move them now. But if you don't, what comes after observations? What does that stand for? Range of motion. So, do you think it's safe to ask someone to move right away? Okay, now that's a judgment call, sorry. I shouldn't really say there's no right or wrong answer to this. It's a judgment call. If they're on the ground and they're like, oh, my leg really, really hurts. If it was fractured, I don't think they'd be doing that. They'd be lying motionless. So if they're lying motionless, fracture test. If they're moving around, active range of motion. That's the safest way to approach it. Okay. Now, if they're moving around, can you say, okay, hold on a second, and then do a fracture test? Absolutely. You can do that too. But every situation is going to be different. But you take pieces from the first part, from your history, add them to your observations, and then add that to your range of motion, and you make the decision. Okay, so if they're lying motionless, do a fracture test. Don't get them to do active range of motion. If they're kind of wiggling around, rolling and stuff, they're kind of laughing, which happens when you get really hurt, then you might get them to do active range of motion. Because your job out there is to determine how are you going to move them, or if to move them off to the side, off to the sidelines. Okay. You do your fracture test. Let's say it comes back negative, and you decide to do a fracture test first. Okay, so you grab their tib in your fib, you squeeze, no pain, you tap down the fibular head, tap down on the medial and lateral malleolus, nothing, the pain's in the middle of the shin. Maybe they got kicked, who knows? You did a compression, you bumped the heel even, you do a fulcrum test, you drop your elbow on it, nothing. Right? Then you can do active range of motion. Well, let me see you move your ankle, buddy. And they do, it hurts a little bit, but they're like moving. Let me see you move your knee. It's fine. You can decide to do passive range of motion and resisted range of motion if you have not gotten enough information yet. Okay? But it has to be clear, and you have to be confident about this. If you're confident, clearly confident that it's not a fracture, move them. If you're not sure, keep testing until you rule it out. And I say this in a general fashion, because apply all these concepts to a spinal injury as well. Because that's a bone, that's a fracture, right? A fractured vertebra. History, I'm not sure if I had a crack, but my neck hurts. Observations, take a look, there's no deformity. They were lying motionless. Would you ask them to move right away if they're lying motionless? Probably not. Okay. How do you do a fracture test? It's fine. You can palpate. What else can you do to determine whether it's a spinal injury or not? What are the things that come out of the spine? Your nerves. Neurological testing. Dermatomes, myotomes, reflexes. Those are your special tests. So in that situation, you would skip this and go right to some special tests, which is your neurological testing. But your number one goal on the field is to rule out a fracture or medical emergency, if you will. Okay? And you can skip steps in this to make it a little bit quicker, but you need to be confident in your decision that it's not fractured. Okay? And then, if it's not fractured, how you move them, we'll talk about emergency rescue moves and field talks. Okay? Now, the other difference is lower body versus upper body. If it's a fractured forearm, it's not angulated, they're holding it, but they can't move, there is numbing and tingling, you did a fracture test, it's fractured. Do you have to split them on the field, necessarily? Some people will argue with you. If it's a CAT exam, you splint. No questions asked. Check pulse motor sensation, put the splint on, check pulse motor sensation, then you move them. That's for the exam. In real life, it might be a little bit different. If they are immobilizing with their hand and you're helping to support and you've got them in a walk assist and they're not getting all shocky on you while you move, that is okay. What if it's angulated? I would leave them and call EMS. Okay. But all those pieces, in all those different types of situations, you'll find in all these different sections. And you can skip sections, especially if you're being more conservative. If the person said, I felt a crack in my neck hurts and I got numbing and tingling down my hands, how much more do you have to do? Nothing. Call EMS. Now, while you're waiting, you can do some of this stuff. But you know clear in your mind, we're not going to move here. So let's just do an assessment and be patient with EMS.
If we're calling EMS, like, do we just like alert someone, get them to call, or do you want us to just call from the field from our cell phone?
That's your EAP. So whatever you establish at your site. Okay? If you're holding the head, don't go into your pocket and just get someone else to do it. But everyone's EAP is going to go a bit different.
You said if the patient has stayed in fluid loss, could do special test palpation off the field.
You could.
Not on the field. Do you have time to keep them on the field?
Good, that's a fantastic question. So, do you do palpation and special tests right on the field? You can. There's something we call the golden period of assessment. Anybody have any idea how long before swelling and all that kind of, about 10 minutes, golden period of assessment, about 10 minutes. So a lot of people will tell you, if it's a, typically the injury, you want to do your Lockmans right away, you want to do your valgus varus, any kind of test right away on the field before all that stuff sets in, because by the time you get off the field, there's swelling and it's going to mess up all your special tests. Do you have to do it right on the field? If you have time. You can. How long does it take to do Lockmans? Done. Somebody hit me, I heard a pop, my knee feels like it's out of place. I don't know if my kneecap's there, it's fine, but I really heard a pop and it hurts on deep inside my knee. I would skip observations. My indices is ACL right away, and MCL maybe, depending if they hit valgus. If they hit varus, maybe LCL. I'll skip observations. I'll skip palpation because I can't really palpate. Well, I might do medial and lateral side, but I can't get into the ACL. Skip observations. Range of motion. With an ACL, typically you'll be able to move a little bit, but if we can do two-person seat carry or walk assist, non-weight bearing, just do walk-ins. Okay, dog's varus. All right, let's go. And you're off the field. So you can do that. But you have to be confident in your decision before you move them. Okay? If you're not confident, do more testing, call your supervisor.